myself, Dr. Sathwik. I'm a cardiologist, assistant professor in Jaideva Hospital, Bangalore. I have been practicing cardiology for past 10 years. I joined my DM residency in 2014 and completed in 2017. Since then, I joined the same institution and I have been working there. This is my eighth year as a consultant of cardiology. So today, basically, the topic is an important one. That is Ticagrelor, often the molecule which we all use. Okay, as a cardiologist, this is one of the important molecules we use in our day-to-day practice because, as we know, CAD, that is coronary artery disease, is one of the important integral component of the cardiovascular disease. Apart from heart failure and arrhythmias and so many congenital other forms of heart diseases, CAD is having an increasing trend. And whenever we treat CAD patients, so antiplatelet therapy regime becomes an integral part of treatment. So likewise, antiplatelet therapy have been evolved over several decades. Okay, so today's in the important drug of discussion is Ticagrelor. So this is a new age antiplatelet medication. Okay, as I was mentioning during my DM days, it was the initially introduced and it was little expensive molecule. We were like whenever we want to use Ticagrelor, it was like price is little higher and a very efficacious molecule. Initially, it was. So our price once it came out of this patency and all, price started coming down, and our widespread acceptance began. So coming to the evolution of antiplatelet drug, so it's therapy basically for the prevention and treatment of the cardiovascular diseases. So one of the earliest antiplatelet medication is aspirin. So even now today, all our DAPT or for that matter antiplatelet regimen is based on a strong foundation of aspirin. Most often, aspirin is one of the important components of the therapy. Without aspirin, like in certain situations, whenever there are contraindications like gastritis or some high bleeding risk individuals, certain in such patients, straight away we switch from aspirin to other well efficacious but less bleeding components. So it came to cardiological use in 1980. So over period of time, so many other molecules have come. So next molecule was aspirin, ticlopidine, one of the important components. Then later came apixaban, maybe into 1993. So later clopidogrel. So this when this molecule was introduced in multiple trials, okay, starting from Capri, so many other trials supporting clopidogrel, it showed a very complementary function along with aspirin because it has a different mechanism of action. And over time, other injectable forms came like eptifibatide, tirofiban. Okay, and in 2001, the dual antiplatelet regimen was introduced as a standard of care in any CAD patients. Then later, more potent P2Y12 inhibitors like Pasugrel came in 2009, and Ticagrelor to begin with in 2011 by AstraZeneca. That was the first company to innovate this molecule. And now the recent and commonly used parenteral antiplatelet molecule is Cangrelor. In fact, it has made cardiological practice, that too particularly in acute ST elevation MI patients where we need immediate onset antiplatelet action. Then in such cases, Cangrelor injection we often use. Mm. Coming to the a lot of limitations are there for ticagrelor therapies. Like as we know, though once the potency starts increasing, it often comes with added risk factors like importantly bleeding, and it could be a catastrophic event. See, for example, if you would have stented a patient, angioplasty would have been done. If you develop some major intracranial bleed or something, then the moment we have to stop the antiplatelet medication, then it becomes very high risk for stent thrombosis. So it's like a double-edged sword. In such situation happen, and also when we use other molecule like mm, what is that prasugrel, it has got certain contraindications, particularly any patients with prior CV or any strokes, it becomes an absolute contraindication. And age more than 65 years, body weight less than age more than 75, and body weight less than 65 kg, they all become relative contraindication for prasugrel usage. However, ticagrelor no such adversities, means in terms of contraindications, absolutely there are very less. Hardly important side effect is like short lasting apnea they can have, means a sensation of catchy sensation of breath. In some individuals, it could be a really a troublesome one. often requiring discontinuation therapy in maybe 3 to 10% of the patients. So coming to the pharmacokinetics and pharmacodynamics of ticagrelor. So first thing is it's a reversible P2Y12 antagonist, okay, and has got rapid onset as well as the rapid offset of action. So onset is so within 90 minutes of its administration, that is loading dose 90 mg, two tablet means 180 mg tablet if we give. Uh, Within about 90 minutes, we could see about 80 to 80%, almost about 70 to 80% platelet inhibition. By about 2 hours, almost 90% platelet inhibition could be achieved. So, though it has got a limited bioavailability, 36%, it has got high plasma distribution by about 99%, high plasma protein bonding molecule, and it has got exclusive hepatic metabolism, and elimination of half life is about 6 to 9 hours. So, it has to be administered twice daily, and as I told, rapid onset of action, and also offset of action is also very quicker, maybe within 3 to 5 days. If we stop this molecule, like say for example, if we take them up for CAG, we would have loaded them with ticagrelor thinking we could fix a vessel, but however if it turns out to be CABG, very bad vessels not requiring PCM, is not amenable for PCI, often goes for CAPG. Then if you would have loaded with clopidogrel, because of its longer duration, that is offset takes about 7 to 10 days, maybe about 7 to 9 days. However, with ticagrelor, it is just 3 to 5 days. Within 3 days itself, we can take them up for surgery. And also, ticagrelor antagonist has also come, probably not yet on widespread use. However, that molecule has also come. Coming to the important clinical trials, so one of the landmark trials for ticagrelor is concerned. Okay, in it came in 2016, and from then onwards, okay, this molecule has never seen any backlog. That has been very widespread use. Here, if we go by the slides, important things, whatever like they have highlighted here. So, one meta-analysis study have shown that Mm, whether P2Y12 inhibitor monotherapy with ticagrelor following PCI, is it beneficial when compared to dual therapy? Okay, so efficacy and safety of ticagrelor monotherapy in patients undergoing percutaneous coronary inhibition. Here it's a meta-analysis. So basically DAPT, it could be a standard DAPT, that is around 6 to 12 months, or abbreviated. Abbreviated means within 1 to 3 months of DAPT, particularly in those with high risk of bleeding. We often give shorter duration of DAPT, then followed by single antiplatelet molecule. Okay, either it could be aspirin alone, or sometimes ticagrelor alone. Okay, so here in this meta-analysis, important things I will highlight over here. So in patients with ACS, short-term DAPT followed by ticagrelor monotherapy resulted in an unchanged ischemic events. However, lower bleeding risk. See, if you give two antiplatelets like aspirin as well as the ticagrelor, okay, then chances of bleeding are a little higher. So if you use only ticagrelor after a shorter duration of DAPT, then this molecule itself will be sufficient enough in preventing the ischemic events, meanwhile not causing a significant bleeding risk. So one another important trial is, so the first landmark trial was Plateau. Okay, that was the landmark trial. Since then, the usage of ticagrelor become class one in any post stenting, either for ACS or for even stable angina patients. So another trial is Alpheus study. So assessment of ticagrelor, whether it's superior versus clopidogrel in reducing peri-procedural myocardial necrosis during high-risk elective PCI. So in any elective high-risk PCI cases, if we load either ticagrelor versus clopidogrel, which is going to be beneficial in preventing the peri-procedure, during procedure myocardial necrosis. Here bleeding risk, if we go in the observation of the study, what they have made, it was similar between two groups. However, platelet function sub-study, if we look at the platelet function, okay, platelet reactivity. So obviously ticagrelor in terms of potency and efficacy is far much more superior than clopidogrel. So it is always better, and efficacy outcomes at 48 hours. Primary outcomes were that is periprocedural myocardial infarction and major myocardial injury were similar between both the groups. So one important thing is, so better platelet inhibition can be achieved with ticagrelor. So another trial here, what they have mentioned is Themis trial. So Themis trial, in fact, I was one of the co-investigator for Themis trial. It was started in 2000, yeah, I think in 2014, and the trial got enrolled patients till 2016. That is around 2 years, 2.5 years. They started enrolling. Basically, here diabetic individuals with stable coronary artery disease. Okay, we know diabetic individuals with the stable CAD at a risk for atherosclerotic cardiovascular diseases. Okay, whether giving aspirin alone versus aspirin plus ticagrelor is going to be beneficial. That is one. That is the whole Themis trial. However, a subset of the Themis trial, that is around, that is called Themis PCI trial. So basically, Themis included 19,000 patients. However, in Themis PCI, nearly about 58% of the patients, those who have been undergone PCI, or those who have undergone CABG, or those with 50% or more coronary artery disease. So coming to the primary efficacy outcome, so in terms of cardiovascular death, comparable, all cause mortality slightly lesser with ticagrelor. In terms of TIMI major bleeding, slightly more with obviously with ticagrelor. So ticagrelor when added to aspirin, overall it significantly reduced the cardiovascular death, MI and stroke in patients with diabetes and prior PCI. So what we can conclude from this is, so any patients who have diabetic patients particularly, who have undergone PCI or CABG. So addition of ticagrelor on top of aspirin, okay, is going to be beneficial in long run in preventing the ischemic events. And another trial they have highlighted is here is Pegasus TIMI-54. So this trial is basically all about extended duration of ticagrelor, that is beyond 1 year. The standard of ticagrelor dosage is means DAPT is 1 year. So if we extend this molecule beyond 1 year, say for further 33 months, maybe just roughly we can tell it as 3 more years. So how beneficial it is? So basically 3 different doses have been introduced. So aspirin monotherapy is a fixed dose, means that is a standard therapy. After 1 year, they were enrolled into 3 groups. One is ticagrelor 90 mg twice daily, another is ticagrelor 60 mg twice daily, and another group is placebo. Okay, so important observation in the Pegasus trial is they found that 60 mg twice daily ticagrelor is as efficacious as ticagrelor 90 mg. Okay, that is the one key highlight inference. And the another key inference is patients who received 90 mg had a slightly greater bleeding risk, obviously, when compared to the placebo versus 60 mg. So, ticagrelor significantly reduced the cardiovascular death, MI and stroke, but increased the major bleeding risk, particularly with 90. So, with this, what we can inculcate into our practice is 60 mg ticagrelor after 1 year of DAPT is beneficial on top of aspirin. So another important, so the clinical, the same thing, Pegasus TIMI-54 assist, so 90 mg versus 60 mg. So overall inference is that. So what does the guideline recommend? So guidelines often recommend that it becomes a class 1 with the level of evidence here. So any patients either stable CAD or any ACS settings in my, even my clinical practice, only if they are intolerant to ticagrelor, like say in terms of dyspnea or maybe any bleeding risk, only except in such individuals, 99% of the time we often load them with ticagrelor, and inevitably we continue them for at least 6 months to 1 year. Okay, and there are certain one trial came whether ticagrelor crushed tablets, means powdered form of ticagrelor, is going to be whether beneficial versus integral full tablet form. So that is called Mojito trial. Relatively small 80 patients they studied. They showed that even crushed tablets, two ticagrelor, the 180 mg crushed, smashed, and then given means dissolved in water and then taken up, or pills, 2 tablets together, and they have estimated the platelet reactivity. See, that is in terms of that is antiplatelet effect of ticagrelor at 1, 2, 4, and 8 hours, and they have found that with crushed tablet, it is relatively better efficacy and better platelet inhibition. However, this trial was not so strong, because only a small number of patients were just about 80 patients. Probably a larger number of patients are required. So this strategy may be useful in comatose patients, those who had a cardiac arrest, or the intubated patients where swallowing of 2 tablets are not possible, or in elderly non-cooperative patients. Such individuals, I think dissolved tablets can be introduced. So in my clinical practice, so inevitably and invariably we are like using ticagrelor, even with a lot of like price control and all, very much beneficial. and we would always try to pass on the benefit to most of our patients, and we have significantly seeing a significantly lower chances of stent thrombosis. Before Ticagrelor was introduced, I think stent thrombosis was very common. Okay, and that too in Indian patients, no, Asian subsets have a higher chances of clopidogrel hyporesponsiveness and unresponsiveness. Maybe one third of the population is hyporesponsive. So in such individuals, always they carry high risk of stent thrombosis, immediate, early, as well as particularly those periods stent thrombosis. So with the advent of Ticagrelor, that risk has also come down. So basically, so it's a reversible P2Y12 receptor antagonist. So it prevents platelet activation, aggregation, as well as the thrombus formation, reduces stent thrombosis. So clinical use, so approved for secondary prevention in adults and those with the prior myocardial infarction. Okay, those who have undergone PCI. Even in post CABG individuals also we give. So in terms of efficacy, it's highly efficacious with better MACE reduction when compared to clopidogrel. So risk always will be there, calculated risk, particularly use judiciously, and particularly in frail individuals or those with higher pre-existing bleeding risk, probably then we can switch to clopidogrel. And also another interesting strategy is after 3 months or 6 months of aspirin ticagrelor combination therapy, just ticagrelor monotherapy has also been found to be very, very much beneficial.